Gastrointestinal stromal tumor GAST is an gastrointestinal disease. Look at this picture shows that gastrointestinal stromal tumor, then CT scan findings. Look at this PET scan for metastasis findings. Look at this, and MRI findings. Now detail going on. Introduction. Gastrointestinal stromal tumor is a rare type of tumor found in the digestive tract, most commonly in the stomach or small intestine. It originates from the intestinal cells of Cajole, which are part of the autonomic nervous system of the gut and regulate digestive tract motility. GASTs are the most common form of mesenchymal tumors in the gastrointestinal tract. Look at this picture shows that gastrointestinal stromal tumor. Etymology. The term gastrointestinal stromal tumor comes from Latin and Greek roots. Gastro stomach, intestinal intestine, and stromal referring to the connective tissue framework of an organ. It describes a tumor that arises from the supportive stromal tissue of the gastrointestinal tract. Epidemiology. GASTs are rare, accounting for approximately 1 to 2% of all gastrointestinal tumors, with an estimated annual incidence of 10 to 15 cases per million people worldwide. They are most commonly diagnosed in adults over the age of 50, with a slight male predominance. Look at this picture shows that gastrointestinal stromal tumor in stomach. Types: GISTs are categorized based on genetic mutations and site. 1. Sporadic GAST. Most common occurs randomly. 2. Familial GAST. Inherited due to mutations in KIT or PDGFRA. 3. Pediatric GAST. Rare, often seen in young females. Lacks KIT or PDGFRA mutations. 4. Syndromic GAST associated with conditions like corny triad. B. Neurofibromatosis type 1. Causes 1. KIT gene mutation. 2. PDGFRA gene mutation. 3. Familial inherited GAST. 4. Neurofibromatosis type 1. 5. Associated syndromes. Example, Carini triad, NF1. Risk factors. 1. Age, typically more than 50 years. 2. Genetic predisposition, family history of GAST. 3. Certain genetic syndrome, example NF1. 4. Female gender, more common in pediatric cases. 5. Ethnic predisposition, more common in Caucasians. Complications. 1. Metatasis, usually to liver or peritoneum. 2. GI bleeding. 3. Intestinal obstruction. 4. Tumor rupture and peritonitis. 5. Recurrence after treatment. 6. Adverse effects of targeted therapy. Pathophysiology. GASTs originates from the intestinal cells of Hegel. Mutations in KIT or PDGFRA genes results in constitutive activation of tyrosine kinase signaling pathways, promoting uncontrolled cell proliferation and tumor formation. These tumors may exhibit variable mitotic rates, and their malignancy potential depends on tumor size, mitotic index, and location. Here is a step by step breakdown of the pathophysiology of gastrointestinal stromal tumor. 1. Origin of the tumor. GAST arises from intestinal cells of Kegel, ICCs, in the gastrointestinal GI tract. ICCs act as pacemaker cells, regulating gut motility. 2. Genetic mutation. A mutation occurs in the KIT gene CD117 or PDGFR gene in these cells. These genes encode for tyrosine kinase receptors, which control cell growth and survival. 3. Constructive action. The mutation causes continuous activation of the thyroxine kinase receptor. This leads to uncontrolled signaling in the absence of normal growth signals. 4. Abnormal cell proliferation. Constant signaling promotes uncontrolled cell division, inhibition of apoptosis, cell death, cellular survival, and tumor formation. 5. Tumor development. A mass forms within the walls of the GI tract, typically in the stomach 60% or small intestine 30%. Tumors may vary in size and growth rate. 6. Angiogenesis. The tumor may stimulate new blood vessels formation to sustain in growth. Angiogenesis. 7. Local inversion or metastasis. The tumor can invade nearby tissues, example bowel wall, mesentery, spreading to distant sites, commonly liver and peritoneum. 8. Clinical manifestations. Symptoms arise due to tumor mass effect, GI bleeding from ulceration, obstruction or rupture in severe cases. Signs and symptoms. 1. Abdominal pain or discomfort. 2. GI bleeding. 3. Palpable abdominal mass. 4. Fatigue and anemia. 5. Nausea or vomiting. 6. Early satiety. 7. Weight loss. 8. Occasionally asymptomatic. Diagnosis. 1. History and physical examination. 2. Endoscopy. 3. Imaging study, CT scan, MRI, PET scan for metastasis or recurrence. 4. Endoscopic ultrasound. 5. Biopsy, FNA or core biopsy. Immunohistochemistry, positive for KT CD117, DOG1 CD34. 6. Molecular genetic testing to identify mutations in KIT or PDGFRA. Nursing diagnosis. 1. Acute pain related to tumor growth. 2. Risk for bleeding related to GI tumor. 3. Imbalanced nutrition less than body requirements. 4. Anxiety related to diagnosis and prognosis. 5. Risk for infection related to invasive procedures or treatment. 6. Knowledge deficit related to disease, process and treatment options. Medical management. 1. Targeted therapy. A. Imatinib mesylate first line. B. Sunitinib second line. C. Regorafenib third line. D. Avapritinib for specific PDGFRA mutations. 2. Surgery, complete surgical resection if localized resectable. 4. Radiation therapy, rarely used, limited to palliative care. Nursing management. 1. Monitor for signs of GI bleeding or obstruction. 2. Pain management. 3. Administer medications as prescribed. 4. Monitor for side effects of targeted therapy. 5. Provide nutritional support. 6. Psychological support and counseling. 7. Educate patient and family about treatment, side effects and follow-up. Treatment options. 1. Surgical resection, curative for localized tumors. 2. Targeted therapy, thyroxine kinase inhibitors. 3. Surveillance for small asymptomatic tumors. 4. Palliative care for advanced metastatic disease. 5. Clinical trialing, emerging therapies and genetic based treatments. Psychosocial medicine. 1. Counseling and psychotherapy to help cope with fear, anxiety, or depression related to cancer diagnosis. 2. Support groups, peer support to share experiences and reduce feeling of isolation. 3. Patient education, empowering the patient with information about disease, treatment, and prognosis. 4. Mindfulness and stress reduction techniques, yoga, meditation, and relaxation therapies. 5. Family involvement and support, encouraging active participation of family in care planning and decision making. Prevention. Currently, there are no specific preventive measures for GAST as most cases are sporadic. However, one, early detection through monitoring in high risk individuals, example with family history or syndromes. 3. Genetic counseling for inherited forms. 4. Healthy lifestyle to reduce general cancer risk. In conclusion, GAST is a rare but important gastrointestinal tumor with distinct clinical and molecular characteristics. Early diagnosis, appropriate surgical intervention, and targeted therapies have significantly improved outcomes. Continued research and individualized treatment approaches are key to better prognosis and quality of life for GAST patients. Thank you. Have a nice day.